Okay, this is the ankle and foot lecture. I'm going to start out with a little bit of an anatomy review, which, as you remember from kinesiology, the ankle and foot are very complex, lots of structures. What I'm going to do is review what I feel are the most important things, important structures to remember and to understand location, so that when we talk about different disorders of the ankle and the foot, it's a lot easier if you've got a good grasp on that anatomy. Okay, so first of all, the joints, and as you can see on the articulating surfaces here, if you had to pick a bone that's probably the most important in the ankle, it's going to be the talus. And with that, you've got it combined with its articulation with the tibia. That would be our talocrural joint or talotibial joint, if you prefer that, giving us dorsiflexion and plantar flexion. You've got the talus articulating with the calcaneus or our subtalar joint. That would give us that inversion and eversion motion. And then you've got the talus articulating with the navicular bone, talonavicular joint, giving us that foot supination and pronation. Looking at muscle function, lots of different muscles there. Lots of your motions are not just created by one muscle, but what I did was put a little check mark by the main player, or at least the muscle that produces most of the action of that particular ankle joint. So if you're looking at inversion, your primary muscle to do that is tibialis posterior. If you've got eversion, it's peroneus longus. Dorsiflexion, primarily by the tibialis anterior, and plantar flexion, both gastrocnemius and soleus would be considered to be dual important in producing plantar flexion. Looking at the ligaments of the ankle, lateral ligaments are the anterior talofibular, posterior talofibular, and calcaneofibular. Those are important to know because you're definitely going to work with a lot of ankle sprains. And then you've got the deltoid ligament on the median side of the ankle. And although that's a very, very large group of ligaments, we kind of collectively call it the deltoid ligament, you're definitely not going to see as many types of ankle injuries or ankle sprains involving the deltoid as you are sprains that involve that lateral complex. Other joints I've kind of listed there. You can kind of review those. There's other ligaments listed there. Some of them are going to come into play a little bit more than others when we talk about different disorders of the ankle and the foot, but those are a good review. And I would suggest either taking out your anatomy book or maybe coming into the lab or taking some time out when you're in class or after class to take a look at some of the ankle models and just help you review some of these structures as well. So we're going to start out with ankle ligament injuries, and by far the most common is going to be inversion sprains, mainly affecting the lateral ligament complex. Usually the mechanism of injury is going to be a combination of plantar flexion and inversion. The forefoot becomes somewhat adducted as well. This is 95% of all ankle sprains are from that lateral ligament complex. And if you look at it in a sports injury statistic, that's going to be about a fourth of all of your sports-related injuries are inversion sprains. So you're going to see it in the sports and non-sports population. It can be someone walking on uneven surfaces, jogging, running, stepping on something kind of uneven, stepping on a rock, that type of thing, uneven grass, going up and down hills, that type of thing. You're definitely going to have a lot of patients with inversion sprains. There's a picture, and that would of course be the anterior talofibular ligament, and out of those three in the lateral ankle, the anterior talofibular is definitely the most commonly affected. Problem sometimes with ankle sprains is that you can kind of have a tendency to re-sprain again. So a person has a tear or a partial tear of a ligament, they get rehab for that, and many times that's still pretty fragile tissue, and so they're kind of at risk to re-sprain, where you may end up just kind of having a person who has chronic ankle instability and chronic ankle sprains. Okay, here would be all the lateral complex. That would be a very severe tear involving the anterior and the posterior talofibular, as well as the calcaneofibular ligament there in the center. Symptoms are always going to be inflammation at first. You're going to have lots of swelling, oftentimes bruising, especially with your grade 2 and your grade 3 ligament sprains. The involved ligament is going to have a lot of tenderness with palpation. Range of motion is going to be pretty limited. Pain is usually a lot more severe if you get a grade 2 and 3. Now remember, grade 2 would be your partial tear, grade 3 would be your full tear of a ligament. When we get to lab, we'll do some special tests, the anterior drawer test. You heard that term before when we talked about the knee, but there's an anterior drawer test for the ankle, the Taylor tilt test, and usually those tests are going to be positive if you have a grade 3. 1 and 2 for grades of sprain are usually managed non-operatively, very conservative management, physical therapy. Grade 3 is typically going to be your surgical candidates, especially depending on how much laxity there is in the ankle. Here's a picture of what a severe inversion sprain is going to look like. You can see all the bruising, you can see a lot of swelling. That's a pretty nasty sprain. And you can definitely tell that just by all of the coloring that you see in the excess fluid. That's really especially around the malleoli area. Okay, so when we're talking about grade 1 and 2 inversion sprains, we kind of need to keep that beginning stage of rehab. Sometimes we still want to refer to that as our max protection phase. We're going to do a lot of education and assist the patient with rest, ice, compression, elevation up to 5 times per day. They should have some type of support, whether it's an ACE bandage, whether it's taping, whether it's a soft air splint or some type of a sleeve type brace. Basically, we're thinking about the fact that we do not want to put the patient into the mechanism of injury, so we don't want them into plantar flexion and inversion. We would like them to be positioned in slight eversion and dorsiflexion. Contrast baths can be wonderful when it comes to getting rid of that swelling. So you're going to go heat, cold, alternating like you guys did in physical agents class. Pulsed ultrasound would probably be the treatment of choice because, of course, we don't want the heat, but what we do want is the mechanical effects of the ultrasound for blood flow. And electrical stimulation is also sometimes a treatment of choice when it comes to the grade 1 and 2 sprains. Typically, weight bearing is not going to be limited. You want the patient to be weight bearing as tolerated. They will probably want to use an assistive device, more so those grade 2s than the grade 1s, but an assistive device can kind of help unweight, especially if there's quite a bit of pain too. If we're going to do some gentle exercises to start with, they're going to be isometrics, especially dorsiflexion and eversion. You're avoiding the mechanism of injury. Going to do that with active range of motion as well. And especially if you're dealing with an athletic population with this type of sprain, we want to maintain that aerobic fitness, strength of other areas during the interim before we can start actually doing a little bit more aggressive work with that ankle. There would be an example of an air splint brace or a joint protection device. If a person sprains their ankle and they go to the emergency room, this is probably what they're going to come home with. We actually have one of these in lab, so I'll have that out when we get to our ankle lab, and that kind of helps you see how that's going to protect both sides of the ankle. They kind of make them universal for both medial and lateral support. Moderate protection phase. So now our swelling is down, our pain is down. We're still going to be continuing with rest, ice, compression, and elevation. We might be able to progress to some cross fiber friction massage, keeping in mind that if there's still quite a bit of swelling, we probably would not want to do that as our treatment of choice. The skin would be too fragile still with all of that extra pressure from the fluid. But once that's down, friction massage is a great treatment for someone with a ligament sprain. We're going to progress to strengthening. We're going to add plantar flexion and inversion as tolerated. Once that person can do active range of motion through plantar flexion and inversion without pain, we can definitely progress with strengthening. And so that might be some simple things like TheraBand or tubing and things that will give just a slight amount of resistance at first. At this point, we should also be weaning the patient from their assistive device. Begin concentric, eccentric strengthening with the weights, heel cord stretching. We don't want to forget about that so that the patient doesn't end up with a really tight heel cord. And now in this moderate protection phase, we really want to start working on that simple closed chain activities, getting on the trampoline, standing, start out doing bilateral exercises and working your way to unilateral, but we really got to get back into some closed chain things and get some proprioceptive input into that foot and that ankle. Finally, the last phase is going to be getting the patient back on some uneven surfaces, so using like the AirX pad, going out on uneven surfaces and that type of thing, doing step-ups. If the person is getting back into a sport, we've got sport-specific drills, isokinetics, if that's appropriate for the patient. Plyometrics, definitely. That's something that's we're going to be doing in lab and looking at a video of some plyometrics, as well as trying some out ourselves, which are going to be very common in athletic rehab for all lower extremity type deficits that patients might have. And so we'll definitely want to incorporate that with a lot of our ankle sprain patients as well. Again, that's not appropriate for everybody. If you're 65 with an ankle sprain, that you probably don't need to get the patient back into plyometrics. At this point, they still might have taping done, or they might have a brace, but that's definitely something that we should be weaning the patient from. Okay, if we're looking at grade 3 sprains, and this would typically be following surgery, this is a slow recovery, and just thinking back to the very poor blood supply that we see with our ligaments throughout the body, this is definitely going to be a long-term rehab for patients. So the progression is the same as what I've just described, but you're probably going to be working at a much slower pace. Normal grade 2 can probably be up and at it in less than 6 weeks, and that's very conservative, even less time than that. But when it's a surgical patient, then you're looking at possibly several months of rehab as well. They may start out with weight-bearing restrictions, and of course that's what kind of gets it's kind of slow out of the gate, is just because of that fact that they have some weight-bearing restrictions. Moving over to the medial side of the ankle, we've got the deltoid ligament sprains, and like we said, it's 5% or so of all ankle ligament sprains are from the deltoid complex. A lot of times if you have a deltoid sprain or you have a deltoid tear, it's in combination with an ankle fracture, and if that's the case, the patient probably has a long period of immobilization, might have undergone an open reduction internal fixation because of the fracture, so they're going to already be immobilized and oftentimes non-weight bearing. However, you can have a deltoid ligament sprain on its own without a fracture, without bony involvement. The problem with the deltoid ligament is that we can usually see a lot of problems with the posterior tibialis function. So plantar flexion, inversion are going to be affected. The PT treatment is going to be similar to the lateral side, except for obviously the mechanism of injury is opposite. So with a deltoid ligament sprain, the mechanism of injury is dorsiflexion with eversion, and so those are going to be the things that we're going to avoid at first. We want to tape the patient or have the patient in a brace that would allow them to be in slight plantar flexion with inversion. Since the mechanism of injury is the opposite, it's the opposite side of the ankle, our treatment is going to be same, other than what motions we're going to progress to and what we're going to avoid early on. Okay, little question for you. Which of the following interventions is used in the initial management phase of an acute inversion ankle sprain? I'm not going to answer that. I'm going to let you guys kind of figure that out based on what we've just talked about as far as what is common when someone has an inversion ankle sprain. So we're not talking surgery, we're just talking conservative management and what would the weight-bearing status be, at least initially. Okay, next one. Skier's ankle is forced into dorsiflexion and the structures supporting the ankle are injured. Which injury has likely occurred and which test would be diagnostic for the injury? This isn't something that you might know yet, but I just kind of wanted to feel you out if any of you would be able to figure this out. And on this one I will give you the answer, and the answer is B, a high ankle sprain with a squeeze test. So in this case, we know, even if you didn't have a clue, you can realize the deltoid ligament sprain, no x-ray is going to show a ligament involvement like that. And if you look into dorsiflexion, then you probably want to get rid of the inversion ankle sprain, because we know that that usually occurs with plantar flexion. And with this one, a grade 3 ankle sprain, you can probably get rid of that just because of the fact that it's not really saying that it's a complete injury. And that might have been your other one that you wanted to choose was D, but the correct answer in that case would be B. Okay, that moves us on to high ankle sprains. And a high ankle sprain is nasty. It can sometimes be a season ender for a lot of athletes if that's who it occurs to. It's tough to treat. Basically, the injury itself occurs to this syndesmotic ligament. Okay, now some people would just call this the ankle syndesmosis. I'm not sure what term you guys used in kinesiology, but this is our very, very ligamentous type structure, connective tissue structure that is in between the tibia and the fibula. It might be in combination with injuries to the lateral ligaments, but typical mechanism of injury is that we've got forced dorsiflexion, so almost an over dorsiflexion motion, and again it's in a weight-bearing position, and the ankle undergoes some type of rotation or twisting during that forced dorsiflexion with weight bearing. Patient gets a lot of pain anterior, just above the ankle, lots of swelling, lots of bruising. The test that we will do in lab is called the squeeze test to kind of determine whether it could be a high ankle sprain. And of course, the patient is going to have a lot of swelling and bruising. Because this is such a deep structure, this is what makes the healing very difficult too, because it's not like we can easily do an ultrasound and hit that syndesmotic ligament. So it's definitely a hard ankle sprain to treat. Okay, if it is unstable, like it's a severe sprain or it's a full tear, surgery is probably going to be indicated for an open reduction internal fixation. And they'll actually put hardware in there. They'll have screws that'll keep the tibia and the fibula together, and then basically that's together while the ligament heals. Oftentimes the weight bearing is going to be restricted, and that could even be up to 3 months if you're looking at having that open reduction internal fixation. And the progression is going to be really similar as far as our rehab goes, but it's going to be a slow progression. And a lot of times that is because if there was surgery, you've got that weight bearing restriction, but also just the long-term healing process is there because of where the structure is located. And so you're looking at probably about 6 months in a lot of cases for patients to recover from this. Unfortunately, what happens sometimes when patients have a lot of ankle ligament sprains is that they end up with a very unstable ankle. So you've got someone who's had conservative treatment of ankle sprains, or they just kind of get chronic ankle sprains that aren't really quite treated like they should be. Perhaps, they come out of rehab a little too soon, or they just didn't have the rehab that they should have. That can really lead to a lot of chronic weakness, swelling, joint instability, and eventually in life that can lead to even osteoarthritis as well. So surgery might be the treatment of choice. They'll actually take that peroneus brevis muscle and reroute it, which kind of helps stabilize the lateral ankle, or those stretched out, very unsupportive ligaments can actually be resected and shortened up and reattached to give the ankle a little bit more stability. So this will vary a lot as far as our PT treatment with these patients. There might be a certain protocol of the physician or of the surgeon, and there's probably going to be a period of post-op immobilization as well. So this is definitely something that occurs mainly if just conservative treatment is not helping, and what we basically have is a very unstable ankle joint. Okay, next section we're going to talk about overuse injuries of the ankle and foot, and I wanted to start with Achilles tendonitis. Basically think of overuse injuries as sort of a body's response or an inflammatory response because of continued repetitive microtrauma. So something is occurring to constantly irritate this soft tissue structure. We're going to see this a lot in the upper extremity when we get to there, as far as a lot of your overuse injuries that are caused by repetitive trauma that's going on in that particular joint or that particular muscle group or ligament group or tendon. Achilles tendonitis is definitely an overuse injury, and with this one we've got aging, tendon degeneration. Sometimes if the foot or the lower extremity already has some degree of malalignment to it. Typical for Achilles tendonitis are patients with pretty tight gastrocsoleus muscles, so heel cords are pretty tight. Sometimes a change suddenly in training or running surfaces, maybe that student has gone from running track to running on cement, that type of thing, or cross country, suddenly beginning to do, a different activity and things like that. And sometimes just very poor footwear. If a person isn't wearing the right kind of shoes for the athletic endeavor that they're doing or for the fitness things that they're involved in, sometimes poor footwear can really lead to that as well. Okay, some symptoms of Achilles tendonitis is that when the person does the activity, they are in pain. And it's pain usually in the lower gastroc. Achilles tendon is usually kind of mid-portion, distal third of the muscle bellies, and definitely on the insertion into the calcaneus. With resistive testing, the patient is going to have pain with resisted plantar flexion. They're going to have pain when the plantar flexors are stretched, so you bring the foot into dorsiflexion. There's probably going to be some degree of swelling down in that area that's affected as well. Treatment isn't going to look really that much different than things that we've seen before. Rest ice, compression elevation, non-steroidal anti-inflammatory drugs. If a person has a lot of gastrocsoleus tightness, a heel lift might really help to sort of decrease that tendon stress, and then that heel lift can be diminished or decreased to a smaller size one as their flexibility improves and they gain a little bit more range of motion throughout that ankle and the gastrocsoleus are not so tight. Ultrasound, phonophoresis, good treatments of choice to get the inflammation down. Definitely we got to stretch gastroc, we got to stretch soleus, we've got to progress to active dorsiflexion exercises. Sometimes these are patients that are so developed in their gastrocsoleus muscles and their tibialis anterior for dorsiflexion is pretty weak in comparison. Doing a lot of eccentric strengthening of both the anterior tibialis and the gastrocsoleus is going to be very, very important as well. And then we want to find out what kind of shoes these people are wearing. Sometimes you'll find out that, flip-flops are the shoe of choice, things that aren't really that supportive, and those are definitely something that can contribute to ongoing pain when it comes to Achilles tendonitis. Okay, moving on to the foot, we've got plantar fasciitis. Some of you probably have that. It's a chronic condition as well. It's inflammation of the plantar aponeurosis. It doesn't have to be that a patient with plantar fasciitis has a heel spur, but certainly a heel spur can aggravate the situation a little bit more. You can kind of see on that picture there what a heel spur would look like. Basically, this person also undergoes some repetitive trauma. Typically, this is a patient with pretty tight heel cords also. Okay, some symptoms is that they may have pain all the way from their heel to the metatarsal phalangeal joints to that even into the medial calcaneus as well. Pain is going to be increased when they dorsiflex, when they bring that great toe up into extension, again because you're stretching all of those small foot muscles. The bottom of the foot can be really tender. You might see that they just don't want to go into a normal heel strike with gait, so what they do is put that foot down flat to start. Just initial weight bearing, like when they first get up in the morning, they've been sleeping at night. Usually at night you're sleeping into some degree of plantar flexion, and when you first stand up on it, that is the person's usually most excruciating pain is when they first stand up in the morning or if they're getting up at night to go to the bathroom or things like that. So anytime that they're in prolonged neutral or plantar flexion position, it's going to be hard when they first stand up and put weight on their feet. Conservative treatment for plantar fasciitis usually involves just kind of changing up some footwear maybe, and that might be hard to do if a person wears high heels a lot. They're so tight, you can't just put that person into a flat shoe and expect them to be comfortable. So they might have to be kind of weaned from that. Arch taping can help sometimes to assist with that. You guys won't really do taping until next semester. Ice packs, ice massage, just even taking like that nice frozen water bottle and rolling the foot on top of it can give a lot of relief. Gastrocsoleus stretching, of course. Any anti-inflammatory modalities like ultrasound or adding phonophoresis with the ultrasound. Even iontophoresis, which I know you guys haven't had yet, but that's basically using electrical stimulation to deliver anti-inflammatory medication into the affected area. Toe stretches and exercises. We don't want to forget about working on our toes. Those are very important when it comes to plantar fasciitis. rolling pin, or like I said, with a water bottle that's frozen. Strengthen those dorsiflexors and do whatever you can to keep the ankles from being in plantar flexion all night long. They can actually wear specific boots that will keep the ankles in a neutral position, or if the patient wakes up, instruct them to get up and stretch during the night. That way they won't have several hours of just straight flexion position of those ankles. Steroid injections are sometimes done if conservative treatment does not work. They may actually go in and take out the heel spur. They may do a release of the plantar fascia area. And there's even been some new things lately with platelet-rich plasma injections, which have tended to give some relief into an area that's inflamed from plantar fasciitis as well. Okay, moving on to what we normally call shin splints, but the correct term is technically medial tibial stress syndrome. This is just a form of tendonitis. It affects the posterior tibialis muscle, a lot of times the soleus muscle. Some cases it can be anterior tibialis, but a hallmark of it is that there is usually a lot of periosteal inflammation. And so, as you can tell, the pain is coming from pretty deep structures, especially in the case of the posterior tibialis. Common causes might be, excuse me, that this is a pronator, person that has a lot of excessive pronation and maybe does not have shoes that accommodate that. Muscle imbalances, flexibility issues, change up of sport activities, especially to change surfaces that the person is completing their sports activities on. And then sometimes eccentric use of the tibialis anterior. It's amazing, like a lot of downhill running, people that train for the Bix race and they're doing that Brady Street hill at the end and they're feeling good and they want to sprint down or go as fast as they can. Going downhill like that running takes a lot of eccentric control, and that can bring about shin splints too. You'll see it a lot in younger kids too, moving into cross country season or into track season and things like that. It can be a pretty darn painful condition for people to have to deal with. And so there are going to be kind of a hallmark of symptoms. What the pain is typically going to be along the distal and medial tibia. That can also be a little bit more medial and a little bit more distal as well. This would usually indicate that it's more posterior tibialis involvement. This would usually be that it's going to be more anterior tibialis involvement. But it's going to be tender to palpation. It's going to be pretty sore throughout both sides of the lower leg. It can be bilateral. It can be unilateral, but it's more commonly bilateral. Not going to see anything on here that's going to be surprising. We want to do ice. We want to do non-steroidal anti-inflammatory drugs, or they're probably going to be put on those. Any type of anti-inflammatory modalities. Some people feel that taping helps as well. Correct any muscle imbalances, strengthen any weak areas, and if it's a pronation problem and it's severe enough, probably referral to an orthotist would be a good idea to see what kind of shoes and shoe inserts this patient might benefit from. Typically, though, going back to the shin splints, typically what you're going to also notice is that when the season is over or when the activity is minimized or there's some rest for that patient, usually the symptoms improve dramatically. Okay, stress fractures. Stress fractures are basically kind of like your mini fractures. They're partial or they're incomplete. They can be caused by a trauma, but a lot of times what they're caused by is repetitive stress. And for whatever reason, the bone just cannot repair itself well with a stress fracture because the person is still undergoing this constant stress. So in the foot area, the common sites are going to be the metatarsals and the lateral malleolus. Pain is going to get worse when they do the activity. It's going to feel a lot better when they take a break. There's actually going to be pain over the bony prominences. And if it's in the malleolus, or it can be even in the tibia, let's say, it can almost mimic the pain of shin splints. So we have to be really careful when we think that we're treating that young cross-country runner for shin splints, that it could possibly be a stress fracture instead. Here would be a couple examples of stress fractures involving the tibia and then involving the fifth metatarsal. And doing an ultrasound over these areas would cause excruciating pain, so that might be a red flag if we were treating it as if it was not a stress fracture because it didn't show up on any x-ray or anything like that, and then an ultrasound is done, and that's going to cause the patient excruciating pain over those areas. A tuning fork can a lot of times be used to detect for a stress fracture as well. Okay, so as far as treatment for stress fractures, definitely rest is going to be really important. It's to get that bone time to heal, get rid of the trauma. If it's a running type injury, we need to rest and not run for a while. If it's workwear, big boots, shoes type of thing, the patient might need to be in something else for a while or not be on their feet all day long. Exercises that are non-weight bearing are going to be the best to do at first. Pool therapy would be wonderful because it would unweight it as well. Modalities if needed for pain, but we're definitely not going to go ultrasound over that stress fracture area. They might need to be put in a walking splint or a boot that would offload that particular area of the stress fracture as well. And then once the healing is occurring, we can progress with our strengthening and we can progress with our flexibility. Okay, let's talk about capsular restrictions of the ankle. The ankle is susceptible to rheumatoid arthritis, to osteoarthritis. With rheumatoid arthritis, it usually affects the feet and the smaller joints more often. Osteoarthritis tends to affect the actual ankle joint complex. When you have patients with gout, that is a form of arthritis, it affects primarily the great toe, the metatarsal phalangeal joint of the great toe. And then you may have people that get arthritis primarily after a period of immobilization, or especially years later. They had a fracture many years ago and they begin to develop arthritis in that ankle. Symptoms when those capsular restrictions are present is the patient may have some swelling. Patient's going to have decreased range of motion. A lot of times they lose a lot of dorsiflexion. The ankle does not move well into inversion and eversion. Of course, they get more pain when they weight bear, so then they don't want to walk. They begin to maybe get deformities as the OA progresses. And with this, if you add in things like diabetes, which already causes foot shape changes, that can make this condition much, much worse when a person has those capsular restrictions, which basically would be a form of arthritis in the ankle. Modalities: joint protection, use assistive devices for gait, range of motion, flexibility, aquatic therapy. If weight bearing isn't painful, or when it becomes less painful, we can begin to do balance proprioception exercises. This is not a patient that we're going to do a lot of high impact stuff with, and definitely take a look at those patients' shoes. Good footwear is going to be extremely important for those patients. Because arthritis can affect the ankle, orthopedic physicians can replace the ankle joint. With this, it's typically replacement of the tibia surface and the talar surface. It's usually indicated with somebody who has pretty disabling ankle pain, an ankle that's pretty much deteriorating, someone that possibly got into a severe injury and it's beyond repair. They may do an ankle replacement instead. There's decreased range of motion in the ankle. It's an alternative to fusing that ankle, especially if the ligaments are fairly good. It'd be nice to end up with an ankle with a lot of motion, and an ankle replacement will do that, whereas an ankle fusion is going to do just like it sounds. It's going to create an ankle that's stable, but that does not have a lot of motion to it. Okay, there's an ankle prosthesis. It's pretty small. The articulating surfaces you can see right here, so you're replacing both the tibial surface and the talar surface. Typically, this is a little bit slower rehab. We think of our hip and our knee replacements. Ankle replacement is going to go a little bit slower. Some surgeons are still going non-weight bearing for a while, but some are allowing patients a little bit of weight bearing from the get-go. But like I said, some are pretty conservative still, and the patient might even be non or touch weight bearing for several weeks. So we can do what we can initially, working around that weight bearing status, transfers, bed mobility, get the other areas strengthened up. But after that period of immobilization, we will be allowed range of motion of the ankle. The weight bearing will progress. We can progress with gait training. We can progress to closed chain, just kind of our typical normal progression, just adhering to those immobilization and weight bearing precautions at first. Overall, ankle replacements, they're getting a little bit more common than they've been for a while. Patient usually has very significant pain relief. They're not going to get back full range of motion at the ankle, but they're probably going to have a lot better than what they had going into the replacement. And some of your typical complications that can occur is that the components can loosen. It might be hard for healing because we are dealing with a pretty distal part of the extremity, so someone who might have had a little bit of impaired circulation, it might take a little longer for the wound to heal post-surgery, and infection is another common post-op complication when it comes to total ankle replacement. Ankle fusions, I've mentioned them but haven't talked about them, and this is typically done with bone grafting. It's done with internal fixation. If you've got a severely unstable ankle, and I'm not just talking just the ligament instability, but we're talking bony instability, perhaps it could have been from a failed total ankle replacement. Oftentimes it's someone with severe fractures, so higher than even a bimalleolar or a trimalleolar fracture. If the ankle is just shattered, sometimes the only way to really create healing and create a stable joint is to fuse it. Typically, they're going to be immobilized with non-weight bearing for gait. You can start out with range of motion and exercise to other areas. We can, of course, work on transverse bed mobility, get the patient mobile. Once the patient is healed up, and they're doing normal full weight bearing, an orthotist consult is going to be essential because there's going to have to be some type of footwear for that patient after the cast is removed in order to accommodate the fact that this patient isn't going to have a whole lot of range of motion left post-fusion. Okay, there would be an example of a fusion done. As you can see, that's going to severely limit range of motion in all directions of an ankle. Okay, so that kind of leads us to fractures, and with ankle fractures we have a lot of fractures affecting the lateral and the medial malleolus. You can have a bimalleolar fracture, meaning both lateral and medial are fractured, and you can have trimalleolar, which means you've got lateral malleolus, medial malleolus, and the posterior margin of the tibia. So you've actually got 3 fractures, and like I said, it's known as a trimalleolar, even though we don't have 3 malleoli in the ankle. Avulsion fractures can occur. Peroneal tendons would be common with that, and as well as Achilles tendon. And remember, with those, the tendon actually is pulling away a piece of the bone from that joint surface. Treatment for those fractures is usually going to involve an ORIF. Sometimes they can't do that right away till the swelling goes down, so they might be in sort of a splint at first and then have their surgery. It might be a pretty clean fracture where just casting is done. And oftentimes with ankle fractures, it's pretty standard that most people are going to be non-weight bearing initially. There can be some variations from that, but most commonly your malleolar fractures are going to be non-weight bearing. There's some examples: open reduction, internal fixation. That would obviously be a medial malleolus fracture. Here would be more of your avulsion fracture, where the Achilles tendon actually pulls away a piece of the calcaneus. Okay, PT treatment. I don't think there's probably anything on there that would be surprising. We're probably just going to be doing isometrics initially. If they're immobilized, we're not doing any ankle exercises, but we might be, if they're in a removable splint, be able to do active dorsi and plantar flexion initially. We're going to do a lot of gait training. We're going to get the patient mobile. We're going to use a walking cast, most likely when weight bearing is allowed. We're going to progress to resistive, closed chain exercises, definitely more aggressive stretching once we can get that patient up in weight bearing. Eventually, we better progress to those balance and proprioceptive exercises. Even though John, our patient, had a calcaneal fracture, you could see this progression is basically what he had to go through with that type of fracture. He was non-weight bearing. Finally, he's getting into some of the more closed chain balance and proprioceptive exercises. And he's actually going to be coming to class again pretty soon so that you guys could see how far he's progressed. Okay, here we have some miscellaneous fractures that can occur. A pilon fracture is a distal tibia compression fracture, where basically we get compression of the tibia surface into the talus. Calcaneus can be fractured on its own, like in John's case. The talus fractures, of course, stress fractures that we've already mentioned can affect lots of different bones in the foot and the ankle. And so our treatment really isn't going to be much different. We have to adhere to those weight-bearing restrictions, of course, and we're going to appropriately progress our strengthening and our flexibility and eventually on to more closed chain and balance and proprioceptive activities. Next thing I want to talk about is an Achilles tendon rupture. With that, and we're going to do this special test in class, it's a Thompson's test, and that would tell us that we might have an Achilles tendon rupture. Treatments can be both non-surgical and surgical, and there's a lot of variability in the research as to which type of treatment is actually better for outcomes. So if you're looking at non-surgical, patient's going to be immobilized in about 8 weeks. There is typically higher re-rupture rates post-surgery or post-rehab on these patients, but aerobic, general body conditioning during the period of immobilization, pretty much if the patient is able to be immobilized and getting around on their own, there isn't going to be a whole lot therapy is going to be able to do until that period of immobilization is over with. Okay, there would be your rupture. And if it's, continued to be a non-surgical patient, after the cast is removed, we might need to add in some thermal modalities, and sometimes moist heat or ultrasound is actually indicated because we're going to be dealing with a pretty tight muscle group, especially the gastrocsoleus. They're probably going to need a heel lift in their shoes, and we could gradually reduce that size. That's usually going to be more coming from the orthotist consult, but we're going to start out doing some pretty simple isometrics, active dorsi and plantar flexion. We're going to progress to resistance as the patient is able to tolerate it, and of course moving on to open or closed chain exercises and balance. We may end up with a patient where isokinetics is appropriate, especially your athletic population. If we have surgical repair, we're still in a period of immobilization, so it has lower re-rupture rates, but the progression is going to be very similar to what I just talked about. We're going to be following those guidelines and weight-bearing status just depending on what type of surgical technique was used. So important to have that good conversation and collaboration with the orthopedic group in order to really know how fast we can progress these patients. Okay, some kind of miscellaneous foot and ankle diagnoses would be things like compartment syndrome. Compartment syndrome can occur in the upper extremity as well. We'll talk about that with upper extremity, but it's more common in the lower extremity. With compartment syndrome, you've got basically acute or chronic elevated tissue pressure, and it's within a very closed fascial space. If you think about the lower leg and the tibia and the fibula and the ligaments and all of the musculature, this is a very closed space with lots of structures within it. And what can happen with compartment syndrome is that you actually get occlusion of your vessels, of your blood vessels, and so we begin to see some compromised function neuromuscularly. So this could be post a tibial fracture. This could be a direct trauma onto a muscle group. This could be a muscle rupturing or muscle hypertrophy. Even people that develop their lower leg muscles, dorsiflexors, plantar flexors to a huge degree, again, we're creating even less space and they can be at risk for compartment syndrome. People with burns, especially circumferential burns, like stepping into a hot tub of water or that type of thing, and even the chronic type of compartment syndrome could be exercise induced. So a person overdoes it, they get this onset of extremely elevated tissue pressure due to swelling, and with that compromise in blood flow, they begin to develop signs and symptoms that are the hallmark of compartment syndrome. Okay. Before I talk about the symptoms, I have probably a unique case of compartment syndrome to talk about. It was actually my husband's college roommate who had played a game of flag football in intramurals, and it was a great game. They won the game, but during the game, he got hit on the front of his shin with a football. So obviously he didn't make the catch, but he got hit on the front of his shin with a football, thought he just had kind of a bad bruise, and at about 1 o'clock in the morning woke up screaming. with all of this huge amounts of swelling and pain in his lower leg, and he basically had a compartment syndrome. They had to rush him to the emergency room. Acute types of compartment syndrome are a medical emergency. They're going to do a fasciotomy. They're going to prevent ischemia, because when you think about that blood flow compromise, that's your biggest risk, is that we're going to end up with death and necrosis of our tissue. Pain is going to be there, usually with passive stretching, paresthesias. Patient's skin might feel kind of warm. It's definitely going to be very tense because of the elevated tissue pressure. Post-acute or post-surgery, we're going to be involved with gait, range of motion, progress back to strengthening and flexibility, but keeping that leg elevated and keeping cold and ice on it is going to be very important to also keep the post-op swelling down. Okay, Morton's neuroma is basically a plantar neuroma. It's a tumor that's benign. It's usually on a nerve. It causes a patient to have very diffuse pain in their toes, in their plantar foot. They feel like the bottom of their foot is burning. They feel like they're getting toe cramps. It's usually not going to be so much of a PT thing. Initially, it's going to be treated with steroid injections, possible padding on the bottom of the shoe. They may actually go in surgically to remove it. And if that's the case, we would probably get involved when it comes to gait training, modalities, relieving pain, and that type of thing. But if we get patients with Morton's neuroma, it's probably not the main reason that they're being referred to therapy, other than if it's a post-operative situation. Okay, just to keep you in mind of some foot deformities that we see, flat foot is pes planus. High arch foot would be pes cavus. Basically with those, we get muscle weakness, we get ligament laxity. The flat foot is usually associated with a pronated foot. Typically this person doesn't have much of an arch, so the medial border of their foot is actually contacting the ground when they stand up. It's, again, not going to be a hallmark of something that people are referred to therapy in droves because they have flat feet, but you're going to have patients with flat feet. And typically with that, besides some strengthening of the foot and ankle muscles, we really probably want to look at referral to an orthotist to help accommodate for that flat foot. Same thing when it comes to the high arch foot or the pes cavus. This could actually be brought upon by certain neurological diagnoses, post-stroke, post-brain injury, and that type of thing. It could even be congenital as far as muscle imbalances go, and kids could be born with that or a tendency to develop a high arch throughout the beginning of childhood. With them, just because of the high arch, the metatarsal heads are where a lot of the weight bearing is occurring, and so there may actually be calluses on that area of the foot as well. Treatment of choice is going to be orthotics in that case. Then we've got our patients with bunions. It's a lateral or a very valgus deviation of the great toe, sometimes caused by improper footwear. Usually these are patients that are wearing too narrow of shoes or for years wore pretty narrow shoes, high heels, that type of thing. They're going to need wider shoes, even some orthotics can help with that. Sometimes surgery is indicated for a bunionectomy, and PT would be for gait training in that case. Okay, then we've got things like hammer toes, mallet toes, claw toes. I'm not going to read all the way through on those, but I do have some pictures so that you guys can see. Here in A, we would have hammer toe. B would be your mallet toe. And again, it's just an idea of where does the flexion occur. Here it's occurring at the PIP joint. Here it's occurring at the DIP joint. And then for C here, we have claw toe, which basically you would have extension here, but flexion occurring at the other two joints. So it really, again, we're not seeing patients for that, but we're going to have patients with that. And if referral to a foot doctor is appropriate, that's probably where we want to go in those cases. The problem with this type of deformities is that it can lead to a lot of skin breakdown, and that's where we really need to be aware of our patients who have those deformities, because they may have skin breakdown starting and they don't even know it. Here would be your bunion or your hallux valgus. Usually if they do surgery on that, it's just an excision of the bone here to kind of avoid this huge gigantic valgus deformation that we're seeing. But bunions can be pretty painful. Having a bunionectomy can be painful. As you can see, that great toe is tucked underneath that second toe, and that's pretty common when it comes to having a bunion or having hallux valgus. Okay, the next slides are just going to be some special tests, which we'll do in lab. That's the anterior drawer test, Taylor tilt test for inversion and eversion stress, looking at lateral and medial ligament sprains in that case. Okay, and then there would be the other part, looking at eversion. Homan's sign is for a blood clot. Basically, we want to dorsiflex the foot and we squeeze the calf. That's an important test to know anyway. It's not 100% diagnostic, but if your patient presents with signs and symptoms of a blood clot, the swelling, the warmth, the tenderness, the pain in the leg, this is a good quick screening test to do, and the patient should probably be referred for a Doppler ultrasound if you suspect a blood clot in the leg. Thompson's test is for Achilles tendon rupture. We'll also do that in lab. And that's it as far as the ankle goes. So that was about 50 minutes. That allows us to hopefully go through this kind of quickly in class and get to lab a little bit more. So please, if you think of any questions as you're listening to this, let me know when you see me and I'll answer them. Okay? Thanks, you guys, and have a great day. Bye.